All right, welcome everybody. Meaning from the last session, but from the previous session, I should say, this is the last session of our day today. So welcome, Adrian. Good to see you again.
Hi, it's great to see you.
Yeah, same here.
I dropped out for a minute, so if it happens again, just play it cool.
Absolutely. No, we'll definitely be able to do that. And we've got Drs. Atreja and Lopez also joining us. So if you guys can hit that in the top left corner, you see your little camera button and mic button. If you can press that, you'll be on video. Awesome. Welcome, Ashish.
Hi, Shahid. How are you?
Good. Doing well. Thank you. Thank you for joining us on our last session of the day. I mean, we're going to talk about, for those of you who have been able to sit with us the last couple of days, we've been talking a lot about hybrid care and lots of ways of how to improve patient experience. But what we wanted to do was kind of like close out the day today with, a toolkit. How do you actually put a lot of this into practice? And with that, we've got you guys who are actually doing this stuff out in the field. So it's great to have you here to help us, build this idea of a digital toolkit for improving patient experience, which of course, Adrian has been focused on, for a long time on peer patient experience with a lot of things at Cleveland Clinic and elsewhere. So we're going to start off with that particular part of the question of what is the current patient experience during the COVID side? And then we'll bring in both Drs. Lopez and Atreja after that to talk a little bit about, well, how are you putting into practice many of the technologies that you're seeing there? And then, of course, we'll have a pretty good conversation there. Of course, on our audience, please, if you have questions, use the chat. There's a room chat and a Q&A button. So if you use the Q&A button, I can easily see the Q&A a little bit easier than if there's a lot of chat going on. So please do definitely ask your questions as we are going. And I'm going to weave them in to this conversation as we go. And then the last 10 minutes, if you would like to come on to video, share the stage with us, you can press the little raise hand button, and we'll give you a chance to show up just like our esteemed panelists are doing here. With that, a little introduction out of the way. Adrian, please tell us a little bit about yourself, what you do, and what's got you busy these days.
Well, I'm Adrian Boise. I'm a neurologist taking care of primarily multiple sclerosis patients, half a bioethicist and a retired ballerina. I spend most of my time now as Chief Experience Officer for the Cleveland Clinic, and it's pretty busy these days, but exciting times.
Perfect. And I know you also at Cleveland Clinic has run. Did you guys run your patient experience conference this year during COVID or no?
Yeah, well, we had actually just wrapped up last week. We had a spectacular lineup, over 2,500 people, which was super exciting. And so I think there's a lot of hunger out there for ongoing dialogue and conversation.
Yeah, that's why it's great to have you here to talk about that particular part of the conversation.
Thank you.
So Esteban, tell us a little bit about yourself and what you're working on these days.
Hey everyone, Esteban Lopez. I am a board-certified internist as well as a board-certified pediatrician. I'm still a practicing doc. I'm the market lead for healthcare and life sciences at Google Cloud. So I have responsibility for the Americas. So the North American market and the Latin organizations across the Americas on their digital transformation journey. So using the power of the cloud to be able to bring things like artificial intelligence, machine learning, natural language processing to improve the provider experience, the patient experience, but most importantly, to help improve clinical outcomes.
Fantastic. Ashish, a quick intro on yourself.
This is great. Hi, everyone. I'm Ashish Atreja. I'm a practicing gastroenterologist, but for the last 20 years, most of my work has been in technology, initially as an informaticist at Cleveland Clinic, and then leading innovation at Mount Sinai. I recently joined UC Davis Health as the Chief Information Officer and their first Chief Digital Health Officer. And the goal is to unify what we call as a traditional world of IT with actually the latest in innovation and digital health, and create a unified experience, not only for patients and family members, but also for clinicians, researchers, and educators. So really excited.
Well, congrats on your new position there. And of course, did you know Adrian when you were at Cleveland Clinic as well?
Absolutely.
You did, right? So we have two one ex and one current Cleveland Clinic. And then Esteban, it's great to have you on. I think it's the first time our two other panelists have been on HealthIMPACT before. But one thing we pride ourselves, of course, in being is a no BS conference. And so I'm going to start with one no BS question. And that is, Adrian, what is everyone getting wrong about how to think about patient experience, right? There's this idea that if you put everybody onto an app, that's a great experience, and that's what you're focusing on, right? And hopefully you can tell by the tone of my voice that that's not exactly what patient experience is about. So what is patient experience about, and what's everybody getting wrong when they think about it?
Sure. Well, I think there's a couple things. The first of which is there's a lot of excitement and sparkliness around cool stuff like you just highlighted. And yet many hospitals are still struggling with how patient experience is actually measured and reimbursed in hospitals. It's not the longitudinal journey that we're all talking about where we're building relationships. It's very focused on the inpatient setting, a little bit of the outpatient setting, but really the inpatient setting drives rankings and ratings for US hospital systems. And so there's a lot of focus on that one tiny setting when we all know the reality is patient experience is much bigger than that, and has nothing to do with the moment you enter our walls, right? And so I think that's a big disconnect. Sometimes I hear at these conferences with cool stuff versus the struggles hospitals are having. And not all of those questions always relate to the things that you and I would think about. You know, quiet at night is something that we're ranked on, but I haven't seen a cool gadget for quiet at night in the decades that I've been a physician. And so I think balancing that is one of it. The second is when I have listened to patients over the years, read their letters, taken their phone calls, sat down with them, reviewed all the comments, you know, the issues are the bookends to care, right? The access to care, the navigation of care, and the billing and the financial transparency pieces. And then they go on to have a life in between. And we don't always sort of think of that as our turf or our responsibility. And as everybody knows, life care is just as important as classic healthcare. So I'll stop there. But the things patients really want are, they want to feel known. They want you to make it really easy. They want to partner with us. And they want to feel cared about as a human being. And those are some of the things that I hope all of us focus on moving forward.
And so if you think about the speakers that came in to the last many conferences, luckily I was able to speak at a past Cleveland Clinic patient experience conference. There is a commonality around leaders that actually focus on patient experience and those that don't, right? There's a bunch of them that like to yap a lot about it and a lot of them that actually do something. Tell us a little bit about what is the commonality of the leaders that really care about patient experience in totality.
Yeah. Well, I have read a lot of surveys that people say it's the #1 priority moving forward, which is great. I think my question back would be, great. When was the last time you walked a unit and talked to your caregivers about their pain points? When was the last time you did the job of the chefs in our kitchens? When was the last time you ate a patient tray of food? When was the last time you were out on the units talking to patients about what's getting in the way? Because I'll tell you, sometimes the disconnect, we actually invite our board members out on rounding every month. And that's critical because it's all fine to talk about it in a room or espouse it at your town halls. But the proof is in the pudding. You know, you have to be out there hearing, I think, the pain of our people. And if last year taught us nothing, it's that the visibility of our leaders on the units to address suffering and the exceptional, I want to say heroism, it's not the right word, because these people do this day in and day out, but under extraordinary circumstances over the last year. So to me, that's the disconnect. And sometimes you hear, oh, we just have to educate patients more. Well, that actually doesn't solve some of the systemic problems in healthcare that get in the way. So those are some of the disconnects I see.
Perfect. So we're bringing you in here to talk about, extend a little bit based on, especially with some of the innovation work you've done at Mount Sinai and where you are now. what are we missing about patient experience there? And then Esteban, as Adrian and Ashish finish out, I'd like for you to, basically comment on the fact that how do you take this kind of input and really build both from your practice experience as well as what you're doing at Google to really highlight and help with tech in the patient experience. So with this, Ashish, please tell us, those two things is, one, what are we missing about patient experience? And two, what's the commonality of the leaders that actually care versus the ones that are just bullshit notes about something on a nice banner that you can put out?
Right. No, happy to. I think building on what Adrian is saying, I think we are missing a holistic approach that marries patient experience with care outcomes and clinical experience, right? So we are trying to solve problems one by one. Maybe exactly like inpatient setting, this is the issue. Outpatient setting, that's. In my mind, patient experience is all about patient needs. And we can still look at all of those in totality. And then we have to start from problem first, which is patient's need first, rather than solution first. Once we have all the needs mapped out, right, access is the biggest part in that, right, in consumerism space, right? And once we have all the needs mapped out, then we look back and say, from a technology stack, how can we have a uniformed digital toolkit which will address both ambulatory, inpatient, peri-surgical space all in one, rather than different technology throwing at for each problem, right? Because patient is a whole, and the experience need to be whole, not fragmented.
Yeah.
So I think that fragmentation still exists a lot. And there's a lot of, I would say, point-and-click solutions, which are easy to implement, but doesn't give the holistic answer we're looking for.
That's right. And about the leadership side, you're new to where you are today. So if you don't want to piss off any of your leaders, that's okay. But talk about what have you seen in your past experience about those leaders? What did they do when they really care?
I would second what Adrian was saying. I think boots on the ground is absolutely critical. I can give example when we were in the middle of COVID pandemic in New York City in last April. David Rich, who was the president of the hospital, did daily walks. While many people said, oh, because of age or whatever, we can't do rounds or whatever, he was up in front and actually boosting the morale of everyone and looking at it, is everyone dressed the right way? I think leaders have to send the right message. And this is lean thinking, where you have to actually know what's happening, boots on the grounds, to be able to impact it, because there's so many dimensions of patient experience. UC Davis, we are creating a Davis Collab, a collaborative, to work with other health systems and health plans and industry to actually share all the use cases so we can together learn, rather than each individual hospital trying to implement it. How can we together learn and be better?
Yeah, fantastic. And of course, for those of you that do know Ashish from many of our past sessions, he is one of the founders at Node Health, which is all about bringing together multiple hospitals and health systems together to build tools, technologies, toolkits driven by evidence, right? And so as we now transition to Esteban, I'd love for you to, if you're welcome to comment on both what Adrian and Ashish says, because you're a physician yourself, you probably have some thoughts on both those topics. But if you can kind of like wrap that around and then say, well, how does Google see this from a experience perspective? Because if there's a couple of things that Google does know, and that is, of course, data, AI, et cetera. But you guys understand experience, consumer experience. So how does that marry up here with what Adrian and Ashish have talked about, and where does Google see itself fitting in that patient experience side?
Well, I'll tell you, as a physician, oftentimes I relate the best to my patients when I'm a patient myself. And so understanding like, oh, that is what that feels like, or this is what my patients are experiencing. Typically, most of us in healthcare, let's say, be it physicians, hospital administrators, tend to be middle, upper income, tend to be otherwise as a population reasonably healthy. And so unless you experience a chronic condition or a serious illness, you're not really going to be in the same shoes as your patients. So oftentimes I see that people focus on patient experience when they've been a patient themselves, especially if they've had a serious condition. But aside from that, I think it's about design, and how do you design around the patient? And I like to think of design not just around the patient, but around the clinician as well, because they're so tied together, and making sure we're designing around both of them and having their, to the point that Ashish made, their needs met. And so Google, of course, is a consumer-facing company. Google Cloud, where I work, is an enterprise or business-facing company. So we take the best of both worlds. And I come from a payer background. I was at Blue Cross and Blue Shield for 7 years. So I like to think of both the payer, provider, patient side of things, as I'm thinking of designing solutions that impact patients real time, and making sure that we're including patients in the design of solutions. And typically what we do in healthcare is not include them in the design, either in how we design exam rooms or hallways or hospitals. Oftentimes it's designed as around our needs, maybe as providers, around the needs of the hospital system itself. And I think bringing the patient at the center and designing around them as the user is a good way to start thinking about the patient experience. Because especially if we start centering the needs, as we think of the underserved as well, we can limit compounding inequities and impacting communities outside of those particular groups. And so we want to make sure that the patient's at the center of the design.
Yeah, and so what are your challenges then? You see yourself sitting in an environment where in other parts of the consumer world, Google has a way of influencing design, approach, use cases, et cetera, because it's a direct relationship that you have with the consumer. In healthcare, of course, almost every experience that we have with patients is intermediated, whether it's on the payer side, whether it's through physicians, et cetera. What are some of the challenges, and how do you think a company like Google, with a great deal of consumer experience, could help break through some of this intermediation? It's a hard problem. There's no easy solution to it. But do you think of it that way with intermediated, non-intermediated use cases?
Well, I think of it in the way that, obviously, I'm a physician who's still practicing laying hands on patients. So I have at least the point of view of the provider. And oftentimes there's a difference between, let's say, the hospital and the provider. As many of us know, sometimes there can be an abrasion there. In what I do on a regular basis, I'm not bringing technology to the table as a solution. I'm thinking of albeit a clinical solution or a business solution. And for me, a business solution is improved clinical outcomes. So it's both, it makes the right thing sense clinically and from a business perspective. So how do we solve problems end to end? Technology is one component of that, and making sure that as we think about the needs of all the users in that space, who is the most important one that we need to design around, or the most important ones? Because I'll tell you, as a doc, I see it all the time in the hospital, is, if EHR systems are not designed if around the user, docs and nurses become slaves to the EHR versus the EHR being a slave to that provider. And technologies can get rammed down the throats of docs and nurses. And I'll tell you, they'll sabotage you each and every time if they're not part of that solution, because they have patients to see. And we need to make sure that they're taking the path of least resistance. I don't know if you've seen, hospital charts. I've seen plenty of them, especially having worked for a payer and doing chart reviews. And it can oftentimes be garbage in, garbage out, right? How many times is the days and a repeat of the prior days? You're not really getting any value in that EHR. You're meeting the needs that the hospital is requiring for you.
Yeah, that's exactly right. And I think that's the point that I was making around intermediation. And so when you have a direct relationship, like a Google does or an Apple does with their customers, a lot about them and how to drive that experience. But in an intermediated way, we've got a lot of problems. So we've got some questions already, as you can imagine, with our audience already flowing in. And so one of the questions that Nick asked is that, as we were already aware, IHI focuses on the triple aim. Of course, you guys know the triple aim. So he's wondering about the patient flow. Like, there's two ways of thinking about this is, A patient has to go to multiple departments during their care, and particularly during COVID, a lot of restrictions and things were put on. So one of the reasons I asked the question about leadership is leadership drives probably 80% of all problems to resolution. But 20 or 30 or 40%, depending on how you look at it, could be the solution providers. So Adrian, what do you think solution providers, technology providers are missing around patient experience, such that when you go into a hospital and you have to hit multiple departments, you can't actually, even if leaders wanted to do the right thing, the technical components necessary to connect these different departments may not be present. So there's a lot of blame and fault that we could place at the leadership, but a lot of it could also be blamed on the solution providers. So let's hit that topic here. What are the things that the solution providers are doing wrong in terms of unified patient experience?
Well, you toss some real softballs, don't you?
We do that here.
I mean, there's a lot wrapped into that, right? Yeah. I mean, the questions based in throughput and the triple aim, there's a quadruple aim is really what we like to talk about. And Esteban was referencing is that person-centered care is when we get to all of it, right? That our own people feel just as cared for as our patients do within our system. And, if you think about the service profit chain, right? It's intimately linked. So I'll take a few stabs, and if you don't like it, you can just tell me. I mean, some hospital systems, for example, don't. I'm stating the obvious, right? But first of all, hospital systems don't all share records. Okay, so if you get admitted to the ER one place and you go somewhere else, I know nothing about you. And if you don't participate in those hospital sharing efforts, it's a huge waste of people's time. It's a waste of the patient's time because I can't see their imaging, and it's a waste of providers' time. So that's a huge dissatisfier. Why don't you know? Why don't you talk to each other? Where's the coordination? Where's the sharing? So that's a pain point. I'll give you another concrete example. I haven't seen, and I'm afraid to say it to this group, but I haven't seen a single cool app or solution for patients waiting in waiting rooms and waiting for appointments. So 30% of patient comments, for example, are about wait times and how frustrating those are. And think about it. It's not just that they're waiting 22 minutes. It's that nobody's updating them, right? So there's no communication. Sometimes there's those goofy signs that say, if you've been waiting longer than 20 minutes, please tell me. Like, we don't already know you've been sitting there for 20 minutes. And of course, when people are afraid and anxious and vulnerable, right, the anxiety just rises the longer that you're waiting with any communication. So that's a problem. And if I was going to throw down a challenge to smart people like yourselves, I would say, like, I get health outcomes and clinical outcomes are beautiful and amazing. But if you're really serious about patient experience, you'd be listening and solving to the problems they have right now. And the right now problems are certainly access, but it's certainly some of these low-hanging fruit, seemingly, like wait times. But again, if you're delayed here, it delays your next one. And then we say we've got policies where we're not going to see you if you show up 15 minutes late. And that's on this administrative tangle web makes people nuts. So that's a problem. And I think, those are two concrete examples that patients talk about all the time.
No, I love that. Those are the kind of toolkit discussions that we need to have. And especially with somebody like Ashish, who's helping multiple hospitals simultaneously kind of navigate through this. And of course, you do that through the patient experience conferences at Cleveland Clinic. Is we've got to get these obvious, what seems to be obvious, but they're unobvious because otherwise they'd be solved. We've got to get this out to the technology providers and solution providers, like that quiet at night. That's a technology solvable problem, because if you had a little Alexa device which knew the ambient noise decibel level and sent an alert over to the EHR,
let's talk about that, because I'm sure Esteban and Ashish will both tell you, and so did Apple tell us, that if you just ask people, hey, what do you want? Hey, is it too loud in your room? Hey, is that keeping you up? They'll say, no. But then when we get a survey back, right, the quiet at night score is one of the worst performing inpatient experience metrics across the board. So we actually did the studies. We ran around and put the little decibel monitors on all the units, and it's a chainsaw. It is a chainsaw level noise. OSHA hitting, problem for our caregivers. Our caregivers are functioning in that environment. And the issue is that there's latent, right, and unspoken needs of patients. So even if they say, no, it's fine, then they get the survey and it's not fine. So we're missing a disconnect between what is the actual noise level and the patient perception of noise. And so to Esteban's point, we absolutely need to do human-centered design thinking to take people offline, interview them in their homes and spaces and say, tell me what quiet means to you, and try to really dig in. And patients are going to help us solve those problems. We don't need to do it around them. I would just pick a different word. We need to do it with them, which I think is the intent Esteban was really elevating.
No, Adrian, your approach, I think it's the same evidence-based medicine principles that we have learned in medical school, with qualitative research first, then quantitative research. I think we need to embed that into practice for evidence-based digital medicine, right? We need to create the science that, the survey got created before any proof of evidence, right? So we're now targeting a survey, which is a surrogate marker of patient experience, and that's why we are splitting our hair in that regard. But maybe we take one theme and go deeper into it, and maybe that's a theme that comes in research, that comes multi-center study or something, and we are able to create a feedback loop. But I also want to anchor, which Adrian pointed out, was, I think, such a central aspect of consumerism. I think just-in-time principle is something that everyone accesses, is now used to at their home or with other industry, right? I need information. I don't need to go to library to get a book. I just open a Wikipedia or Google, I get that information, right? I go to make a flight. I don't have to be on a phone with the person who's going to tell me what options are there. I go to Kayak and make that. And if I have to get a boarding pass, I don't have to wait in the airlines. I can actually do it right from my phone using a text message. And that concept is the heart of consumerism, the right thing at the right time to deliver the right process and ultimately right action, right? And I think we need to measure that as well. We need to have and phone line. We should not have a phone line which is more than 1 minute or more than 30 seconds. In fact, we should not have phone lines at all. People should be able to get to make an appointment, get to the right referral through a chat, right? And that's something we're learning a lot, this new kind of experience, these new interfaces, a chat interface, a text interface, a conversational interface, are actually taking away much more manual interfaces. And the benefit of that is you can automate those interfaces. So one person can digitally chat with an automated bot. A million patients can do at the same time, versus having one-to-one employee, which is kind of putting up a phone call. Even if it's a manual person you have to give, and maybe I'll bring up a slide on that. We did something in COVID. We were able to reach out to 1 million patients when we were in New York City, right? This left slide. We could never have reached out to 1 million patients one by one through a phone call. This is the peak of the pandemic, right? New York City was in the ice storm last April. 1 million patients, we told them, like, these are the best practices, because they were getting conflicting information based on the news channel they go to, right? And then we gave them an option of doing digitally monitoring themselves with an AI bot. 55,000 people recruited themselves in 4 weeks for that, 4 to 8 weeks, right? Without a single manual coordinator. So this is an example of, Shahid, what you were saying is non-intermediate, non-remedy. There's no person there, but you can do light touch and you can scale it to millions of patients. But then what you need to do is, once you do that, you may need heavier touch after that, because people need more than just information. And I'm sharing what we did with digital navigation for colonoscopy, where the main challenge is we give a paper-based instruction to a patient, hey, come for colonoscopy. 50% of people lose the paper by the time the procedure comes. 1 in 4 colonoscopy have actually stolen when we go there. So then you can do digital navigation, where it can actually guide a patient what their appointment time is, driving direction, parking direction, and how step by step what they need to do to 10 days for prepare for colonoscopy, right? And this is something that I will have to spend 15 minutes with a patient to do it, but patients will forget after I spend time. But we can record our voice or video and embed them. So I think the central aspect of patient experience, what we need to marry what technology can do for one-to-many care. Once we find the best practice on certain things, what Adrian finds, you find something best for noise, you are able to then make it a standard of practice and really disseminate it that every patient gets it. And
Yeah,
that's
I just want to add something, which is we have to be crystal clear how we are measuring patient experience. I mean, I wrote a call to the field last year about the metrics are broken. So we're all talking about in time, and he's absolutely right. But hospitals are measured by a survey that comes back 2 months later about their experience. And I'm not allowed to survey while you're in the house about your experience before that survey goes out. So you want to talk about reality. I mean, the reality is we say experience as though that's all this consumer cool stuff. No. Healthcare is focused on this because this drives raters and rankings and, evaluations and JCO, blah, blah, blah. And so until we break that, we're not going to get the patient experience that looks like this. And so we've got a chain around our foot, and that metric is broken. So I agree we need new metrics for patient experience more broadly, but we got to get there together.
And I think that's your point, right? I mean, that's the point. We're measuring the wrong stuff. We're working towards those surveys, not towards the patient. It's him or herself. And, Ashish is showing contact center artificial intelligence. We want contact center artificial intelligence in an omni-channel type of way, because my 83-year-old dad, he's going to call, right? He's not going to engage with a chat bot live, but we can still have a human-sounding virtual agent on the other side of that telephony that's going to speak to him in Spanish with a Mexican accent. It's not going to sound like a robot, and give them that experience. But my Gen Z daughters, they don't want to call anyone, right? So they're going to engage on their phone, either on an app or direct on the site, still with the same virtual agent. But we need that to be available through telephony, through web-based, through mobile, and through social media.
No, I love that. In fact, when you think about the solution space or the innovation space, one thing we've all learned from Ashish over the last few years, and Adrian, you guys are doing this a lot at Cleveland Clinic as well, is don't wait for the solutions to come to you. If they're not coming, build the darn thing, right? And this is where it's really exciting with Esteban and what team you guys are doing to make all of these massive tools that are sitting behind huge Google data centers available at the point of an API, right? So what the magic that Ashish is talking about as far as the delivery occurred because he didn't wait for someone to supply that. They said, there's a bunch of APIs, we can go connect to you, we can build our own, etc. So Esteban, talk a little bit about that. Is how much of the focus around what you're doing is for the typical innovation community in the sense of ISVs, meaning independent software vendors, guys like us who make software for a living, versus what are you building with respect to Google to allow Ashish and Adrian to just make something that they need tomorrow, rather than wait for engineers like me to come and build it. So can you talk a little bit about that, what Google's doing?
Yeah, absolutely. So I got really excited.
Something good, Esteban.
I got really excited when I saw Ashish's slide, because obviously that's kind of the bread and butter of what I do. I think digital is the foundation. Digital is next, and we need to be moving towards a digital foundation in healthcare, not to necessarily substitute the face-to-face hands-on, but virtual care is not just a telehealth experience. It's going to be I consider telehealth the video experience, but I'm talking about the end-to-end care. So starting with the virtual agent, seeing the provider real time, having her have clinical decision support, having me have patient support on my end, and then wrapping that up with an agent on the back end as well, that's scheduling your next appointment. But we need, as a healthcare system, to move platforms from on-prem into the cloud that's going to be digital based in order for us to have the capabilities that we need around artificial intelligence, machine learning capabilities, natural language process, all of those things that are going to make our lives as physicians or clinicians better. That's going to make the administrators' lives of the hospitals better, and is going to make the patients' lives better. So to your point, there are technologies that Google is building in the work that I do at Google Cloud, and we have engineers that are specifically dedicated to the healthcare space. Things like our healthcare API, our healthcare data cloud, our device data cloud. Those are technology solutions. We do work with an ecosystem of ISVs or other partners in the ecosystem as part of that go-to-market solution, working with healthcare entities. So I'm very, as you can hear in my voice, I am very excited about the future, because the way that we're engaging in healthcare is going to be very different in the 2030s than it is now. And then it was definitely when I trained in medical school, when I graduated from medical school in 1999. And it's very exciting, because we're going to have less physicians and less nurses to take care of more patients. We need the capabilities of artificial intelligence and machine learning to be able to empower clinicians to work at the top of their licensure, doctors, nurse practitioners, PAs, nurses, in order to care for our population, not just in the US, but around the world.
No, and that's great advice here. So when you think about the problem that we were saying, is that, do you wait for solutions? Do you hope that the EHR vendors of the world or these digital health innovators of the world will just bring everything to hospitals? I don't think we can anymore. I think we need to make sure that we're focused on being able to build our own solutions, because one thing that we know all hospitals have been in the last 50 plus years is as an integrator of technology. You take buildings, you take people, you take technologies like surgeries, surgical beds and surgical equipment, you put it all together, and then you care for patients. So we seem to be okay as hospital buyers putting things together in other areas, but it looks like we wait for a lot of these big tech to come in. And so to our panel, to our audience, remember, if anybody wants to come on live, we're going to go ahead and take you guys to come on live. But we've got some questions coming in. I'll ask the question.
Let me just address that point real quick. The problem especially in the United States, is that that medium-sized community hospital or hospital system in East Texas, they don't have a budget or the capabilities to build it on their own. So they want to buy off-the-shelf capabilities. But a large, national hospital system has the budget, has the tech, has the engineers. So we need both, right? We need technology solutions that are off the shelf, but we need hospital systems like Cleveland Clinic, who has the budget, the capability, and the expertise to be building solutions as well. So I think it's a combination of both.
Absolutely. And one other, very provocative thing is that currently, at the moment, one way that whether it's Google or Microsoft or Oracle, one way that we as engineers build upon each other is we have a very vibrant open source ecosystem. That just aside from sharing a little bit of attributed research, there's not really a whole lot of open source sharing going on. That tool that Ashish built at Mount Sinai is fantastic. Why isn't every hospital using it? Well, because there's no way to organize that into an open source sharing model. There's an enormous amount of things that Cleveland Clinic does, but of course, it's not just available for everyone to use. And I, as an open source author, I've got thousands and thousands of lines of code sitting around that others can use. That is something we are missing in the healthcare community. One thing, that I've been pushing for the last 10 plus years is whatever we build in one hospital at the Mount Sinai's or the Cleveland Clinics of the world, they're not your competition down in East Texas. Let them have it, right? Build a model. Nobody's going to sue you for it. Nobody's put it into an open source model. Let it shift down, because there are tiny software companies that use open source stuff that Google makes today to give them the power. All the AI stuff that you build, Esteban, at Google, you open source that and you make it available so little software guys like me can use it. The model is there. We're just not using it in hospitals. That's kind of like what I'm complaining about a little bit here.
If I can anchor that,
yeah,
I think build versus buy depends on the capacity of the organization. But I'm wondering if partnership or collaboration should be the dominant strategy. right? Because no matter how big a health system is, we cannot build, and neither we should be.
Correct.
Right? Because just look at security aspect, cloud aspect. The problem is already solved somewhere, right? So we have a philosophy: if the problem is solved, there's so much other bigger problems to solve. So partnership, we first think of partnership or collaboration. Then we say, if that is not there in that, what do we build or buy? And I'm wondering if that will come to, that actually addresses your question: how do we build a partnership around open source initiatives or common set of tools to give a unified experience or operating system for digital health?
Yeah, absolutely. And I think that's really where, companies like, organizations like you guys have started out with Note Health, and what Adrian and team has been doing. That's what the idea behind the Cleveland Clinic's patient experience has been, is these such vibrant communities. We share ideas, but in the modern world, ideas are completely useless if they're not tied to software and code. Software and code gets installed and can be used. Ideas, that's my problematic. I'd love for Adrian to push back on that. Go for it.
Well, I had a big idea, and the idea was that there would be some magic we could create at the bedside if we put a poster behind the patient's head that said, "Tell me something about yourself," and the patient could fill it out.
Oh, nice.
So that we would know they were a veteran or a, fire jumper or a retired nurse. That requires no code. And in fact, I've been very frustrated with the idea that for all the cool technology we have, I still can't generate that human conversation at the bedside where it needs to occur. It doesn't help me understand who that person is or what book they were reading last week, which I find an absolute travesty, quite honestly, because we're in the business of humans and we're in the business of relationships. So tech for tech's sake is a waste of time. Tech that enhances relationships, tech that makes their lives easier, tech that enables teamwork, tech that, that we're interested in. And that bore itself out in an AMA study from a decade ago, that clinicians would only adopt the things we used if it was made their relationships better, kept their patients safer, or reduced burnout. And so not everything needs code. And in fact, sometimes I'm so impatient, I'll use that word, impatient with what's coming, that we forget the basics, that there's no reason you can't scribble on the whiteboard, "Hey, this person loves raspberries." You could go in and create a moment. And guess what? That drives empathy and trust. Susanna Rose led that research.
To help you out, Adrian, in this case, the reason why that's also code is I can create the PDF sitting with you in one collaboration session, post it up on GitHub or on somewhere on Google or Microsoft, and it is now available to everybody in the entire world. It's everything today.
You're talking.
You're taking my idea. It's not my idea.
Question on the chat. Let me present that to you guys. I think you guys will like it. So Tang, I think I'm pronouncing the name properly. He says, "Hello, I'm in IT technology, and my colleagues are far removed from patients and clinicians. Often our interactions, being in IT, are negative because they call us only when there's a problem, but we don't have the opportunity to contribute to the patient experience." Ashish, any comments there? And then Adrian and Esteban, you guys can jump in as well. We only have a few minutes left. If you guys have more time, we can take it a little bit longer, but what's your thoughts on that question?
This is such a terrific question. I think what happens is, I have seen time and again, the employees feel disenchanted with, I would say, IT. The way things evolve, we believe you cannot give a great patient experience if you can't give a good employee experience. Right? So when we talk about digital Davis experience, it's a unified experience for patients as well as employees and researchers. It's the same thing. If we don't decrease the burden on clinician, how can we expect them to give a stellar experience to some degree, right? So we have launched an initiative, it's actually about to be launched, called Help Make Us Better, where we are opening completely our door to say, just provide any feedback, and it's a community board, completely open to UC Davis, where anyone can put any idea, other people can rank it and upvote it. And then the leadership reviews it, and then we take them, actually award people when we build on that. And the person who suggests it is actually becoming part of the creation of the tool, if we do well the tool. And this is actually reminds me also of smaller project we did called My 2 Cents in Cleveland Clinic in 2001. So it's not about technology, it's about using tools. Humans are about tools. How can we use tools, whether those are analog or digital, or communication as a tool, to actually bring people together and build on top of each other, and really create everyone. Our goal is everyone should be innovator. We changed our IT first day, not from information technology, but to innovation technology. And I think every employee should be innovator and given an equal chance to contribute, and in a very transparent manner.
Right. And that sounds fantastic. And so we are out of time on our core. Do you guys have a few extra minutes? There's some more questions that have come in. If you guys can take that, that's great. Anybody that has to leave, please do. So there's one question that I think, Adrian, you might find interesting to answer as well, is what is your perspective on treating the patient? Chris McFarland asks, what is your perspective on treating the patient more as a consumer with healthcare options and guiding them through the healthcare options? And love for Esteban to also comment on that, especially from the payer angle, which does treat patients, quote, as consumers. So Adrian, is there a hope in treating patients as consumers?
Well, I wrote a paper. You'll be happy to know, because I was frustrated with this camera. It's a resounding theme with me, I guess. But I have a fire in my belly to make this better. Yeah. And we use those terms interchangeably, patient and consumer. And as I ran down, consumer of goods, right, that they should be the same thing. You're a consumer of healthcare. But the truth of the matter is, if you're a consumer, you have choice. Patients don't have choice when they have a brain bleed and get rushed to the hospital in the middle of the night. Their insurance may dictate where they go, right? Their location or their emergency may dictate it. They don't have transparency of costs, if we're all being honest with each other, right? You get an estimate maybe of what your cost might be. As you would if you were shopping at the grocery store, right? I know the cost of everything I put in my cart. That's not true for patients. And the last thing that I want to just hammer on is the vulnerability and fear that not every one of our patients, you look like empowered, engaged people who, if you are patients, are probably pretty engaged in your health. But that's not the case for the average patient that we see. We in Cleveland, we have an area deprivation index of over 80 for many of our African-American patients. These are not, we need to be careful about thinking that these people are running around checking their patient portal and wearing all the gadgets, because they're not. And so the vulnerability and the disparities that exist, the fear that can often drive suffering in healthcare, it will forever distinguish patients from consumers, in my mind, in any other industry. And our job collectively, right, is to empower patients with those capabilities so that we can level the playing field a little bit more. But that vulnerability is a precious thing that it's a gift our patients give us. And I want to honor that trust that they're placing in us, and not simply thinking they just have choices and all the rights everybody else does, because fear does amazing things to the human brain and body. So.
Absolutely. Those are such wise remarks, because it's coming from a person like you who has literally been leading the effort around patient experience. So one would imagine that if anyone was going to say, yeah, they should be consumers, it would be you. But I think that caution is very, very important on the vulnerability side. So in the last minute or so, if you want to take us home, Esteban, talk to us about your payer angle and tell us, what did you learn about consumers versus patients back there?
Well, I'll tell you from both the tech and the payer angle. I diverge a little bit from where Adrian is sitting. I would say that if you're a young, healthy individual, you're very much a consumer. My kids, who are millennials and Gen Zs, my girls are 28, 24, 22, they have choices and they look for those choices, but also they have privilege. I also agree that not everyone has choices. Clearly, you're showing up with the brain bleed, you're showing up and being seen by whoever is going to see you in that scenario. But think of it from like a retail perspective. We tend to have choices. Like our dentists tend to be very responsive to us. Our vets tend to be very responsive to us, more so than what I see in the healthcare system. I want to honor the fact that some patients do have those choices. I don't necessarily 100% see them as just consumers, but a lot of the searches in healthcare, like the first step often is with Google or YouTube. And so potentially thinking of them as consumers by meeting them where they are in their journey of health. It's very different if you're, a young, healthy individual and not having that stickiness with a PCP. As a primary care physician, I get concerned about that. If you're just going from one physician or provider to another, you don't have that continuity, and that's what worries me, especially with younger patients.
Got it.